IRDS, we have involved in other systems, for example, the renal system, hepatobiliary, gastrointestinal, cardiovascular, central nervous system also may be affected. If one asks, have been reported liver involvement in adults with COVID-19 in many research. Now, in our study, we have the prevalence of liver dysfunction, type of enzyme rearrangement, and impacts on outcome. It has remained unclear. This is the idea for our research to start with. And our research, we have found a link between COVID-19 infection and higher liver enzymes, suggests that the virus may damage the liver either directly or through an immune response or through a medication toxicity. Usually COVID-19 related hepatic damage is defined as there is increasing in the ALT and AST liver enzyme more than 3 times of the upper normal limit, or an increasing alkaline phosphatase or total serum bilirubin more than 2 of the upper normal limit. Usually below 3, it is not a liver damage, we have excluded from the study. The degree of hypoalbuminemia, it is one of the markers for liver injuries, but in the study and the research have been excluded and made as non-specific. And as we know, the virus have a spike attached to this receptor and make an expression on the cell that the formation of the messenger RNA, and the messenger RNA starts replication of the virus inside the cell. Is this receptor found only in the respiratory system? No, it can be found in other systems. For that reason, a COVID-19, it is not limited to the other pulmonary system involvement, or it can be on other systems, so that we have faced many cases that are usually presented with GIT symptom and there is a free of the pulmonary system. Why? Because of this receptor has been found in the intestine and the duodenum, pancreas, liver, cardiovascular, brain, and so on. The aim of the study, it is to estimate the prevalence of liver damage among hospitalized COVID-19 patients and try to identify those who are at risk. Our study, it is a cross-sectional observational study, took place in a single center in Al-Basra Teaching Hospital. About 280 patients hospitalized have been enrolled in our study, and all those patients have been diagnosed with COVID-19 by a clinical and by the CT scan, radiological, and the PCR. Information have been collected either by direct interviewer, examination of the reported measure depending on the case or the patient state. The age have been classified into 3 major groups: those patients below 35 and those patients between 35 years to 65 years and those with more than 65 years. And the gender, sex, male, and the comorbidity disease, diabetic hypertension, and cardiovascular system, and other, etc. Those patients enrolled have been divided into major groups: those who have been admitted to the ICU and those who have been admitted to the clinical infectious ward, usually depending on the state of the patient and the O2 saturation. The duration of hospitalization has been classified usually into 3 major groups: those who have 5 days, and those from 5 to 10, and those who stay in the hospital more than 10 days. The presence or absence of the cytokines or release syndrome, which measure clinically and biochemically uploaded as present. Usually cytokine syndrome or hypercytokainemia, usually one of the major complications that lead to IRDS and respiratory failure, and the most common cause of death. This is usually because of the releasing of many cytokines, اللي هو interleukin 2, interleukin 6, interleukin 10, and immunoglobulin. These result in usually a severe damage to the endothelial cell and other systems. The lung involvement have been classified by CT scan more than 50 and less than 50. The oxygen saturation into